Welcome to the OPA webinar, Ohio's Opiate Epidemic, What Psychologists Need to Know. I'm Joan Bowman, Director of Membership and Education. Before we move on to today's topic, I'd like to issue an invitation for future webinar presenters for OPA. Contact me at the email address or phone number on screen, and I'll be happy to answer any questions you may have. In order to receive your CE credit for today's presentation, you'll need to pass the webinar quiz. The quiz and answer sheet are both available on the website webinar page. Please return the completed answer sheet with payment, get a passing score of at least 80%, and you'll receive your CE. Please allow 1 week for the credit to appear in your MCE record. Our speaker today will be Dr. Karen Dapper. Dr. Dapper is currently employed as a clinical supervisor for CompDrug. In addition, she serves on the clinical faculty for the School of Professional Psychology at Wright State University and is an adjunct professor for Park University and the Social Sciences Department. She was previously employed as the clinical director of mental health services at the Ohio Reformatory for Women for many years. At this point, I'll turn the presentation over to Dr. Dapper.
Ohio's opiate epidemic is catastrophic and growing. Psychologists today need to be aware of this problem so appropriate and early intervention can take place for their clients. Specifically, since 1997, opiate distribution has gone up continually with grams per 100,000 persons in 1997 at 11,768 to a forecasted rate of 91,887 by 2010. And as such, the death rate due to unintentional fatal drug poisoning has mirrored the rate of opiate distribution over that time period. In fact, if we look at unintentional drug overdosing in Ohio from 1979 to 2011, we can begin to see that prescription drugs are causing a larger overdose epidemic than previous illicit drugs ever have. Specifically, problems with heroin and crack cocaine during the late 1970s through the late 1990s never came near the rates of overdose that we are experiencing today due to prescription opiates. So, how do these numbers correlate with actual client treatment admissions? Data obtained from the Multi-Agency Community Information System in 2013 notes that in 2001, the highest concentration of opiate admissions were in Cuyahoga, Montgomery, Mahoney, Summit, and Franklin counties, while Noble, Paulding, Putnam, Wyandotte counties had no admission for opiate-related treatment. However, by 2003, the number of counties with 6.8 to 16.3% admission rates of clients for opiate treatment had grown significantly, with the highest levels of admissions in Cuyahoga County at 16.3%, Mahoning County at 15.8%, and Montgomery County at 14.9%. While during the same time period, Paulding, Putnam, and Wyandotte counties still had no opiate-related treatment admissions. Only 2 years later, in 2009, the rates of treatment admissions for opiate abuse and dependence continued to climb, with the highest rates of admission for treatment in Scioto County at 34.4%, Clark County at 21.1%, and Jackson County at 20.9%. At this point, all counties were reporting admission rates, with Holmes, Morgan, and Henry counties having the lowest number of opiate-related admissions. In In 2 more years, 2007, again the opiate epidemic continues to expand across Ohio. By this time, Jackson County is reporting a 31.4% admission rate, closely followed by Scioto County at 30.8% and Lawrence County at 22.7%. Then, in 2009, most of the state of Ohio is now covered in red, with client admissions as high as 64.1% in Scioto County, 49.5% in Lawrence County, and 35.7% in Jackson County. Then, as of 2011, rates of treatment admissions had reached as high as 70.2% in Scioto County, 56.2% in Lawrence County, and 49.9% in Athens County. As one would expect, during this same time period, the percentage of AOD clients with active opioid diagnoses have also risen at an ever-increasing rate, from 7.2% in 2001 to 28.5% in 2012. Consequently, it ultimately became important to see how heroin was infiltrating the prescription opiate-addicted population. In 2012, a hotspot analysis by zip codes was developed to locate the number of clients in treatment for heroin addiction. The hotspots noted on this map and colored in teal indicate clusters of zip codes with statistically high levels of heroin-addicted clients. By contrast, this map uses hotspot analysis to indicate those areas in teal which note statistically high levels of clients in treatment for prescription opiate addiction. As you can see, many of the areas noted overlap with those demonstrating high levels of heroin-addicted clients. This should be noted as many opioid prescription drug abusers often progress to heroin addiction over time. Furthermore, with the epidemic proportions of this problem, we are finding increasing numbers of newborns addicted to opiates. Neonatal abstinence syndrome, or NAS, occurs when a baby is born addicted to opiates and must go through withdrawal after birth. The MOMS Project, or Maternal Opiate Medical Support Project, focuses on interventions to increase prenatal treatment as a means to improve outcomes for both mother and infant, and subsequently reduce the cost of NAS to Ohio's Medicaid program by shortening the length of stay in the neonatal intensive care units, or NICU, for an NAS infant. The primary MOMS Project goals include the development of an integrated maternal care practice model with timely access to appropriate mental health and addiction services that extend beyond the postpartum period to include intensive home-based or residential treatment. The project focuses on identifying the best practices for obstetrical services related to medication assisted treatment before, during, and after delivery. This includes assisted opioid-addicted mothers through methadone or like medication options during pregnancy, as withdrawing a mother from opiates during pregnancy often increases the level of risk for both the addicted mother and the addicted fetus. The project also includes the development of a toolkit to support such obstetrical practice. Furthermore, the MOMS Project includes the development of a pilot project and evaluation of promising practices in 2 to 3 sites that will integrate this model into existing obstetrical practices. The total budget for this project stands at $4.2 million and includes such project partners as the Ohio Department of Mental Health, Ohio Medicaid, and the Office of Health Transformation. As with the previous graphs, this graph of pregnant or parenting opiate clients with a diagnosis of opiate addiction has increased from 2,795 clients in 2004 to 8,307 such clients in 2011, as reported by the Multi-Agency Community Services Information System. As such, diagnoses of opiate abuse or dependence at the time of delivery demonstrates the same levels of increase in red, from 407 in 2007 to 1,061 in 2011. During that same time period, in blue, you can see the decline in cocaine abuse and addiction at the time of delivery, from 709 in 2007 to 368 in 2011. Likewise, this map indicates the number of pregnant or parenting women with an opiate diagnosis at their time of admission, with Franklin, Cuyahoga, and Montgomery counties with the highest percentages. In 2011, 8,320 Ohio women met this criteria. Consequently, from 2004 to 2011, NAS, or neonatal abstinence syndrome, inpatient hospitalization rates rose per 10,000 live births in Ohio and increased from 14 in 2004 to 88 in 2011 per the Ohio Hospital Association. Likewise, during that same time period, 2004 to 2011, the number of inpatient hospitalizations resulting from exposure to opiates through breast milk or the placenta also rose significantly, while such exposure declined for cocaine but remained fairly stable for the hallucinogens. Therefore, this brings us to the importance of medication-assisted treatment. Two such medications include buprenorphine, which is a partial opiate agonist and comes in the form of a daily sublingual tablet and was approved for such use by the FDA in 2002. As an opiate agonist, it works in a manner like that of an opiate and can be used in place of an opiate. Suboxone is also a partial opiate agonist, and in combination with buprenorphine and naltrexone, it comes in a sublingual tablet or film and was approved by the FDA in 2002. In addition, Suboxone may be prescribed and dispensed by qualified prescribers in treatment settings other than traditional methadone-like clinics. The population most likely to benefit from Suboxone are those clients 16 years of age or older and with a short history of opioid dependence. To other such drugs include naltrexone, which was approved in 1984 for opiate addiction and serves as an opioid antagonist, or it works against the opioid group, blocking opioid receptors, and Vivitrol, which was approved in 2006 to treat alcohol dependence and then later in 2010 to treat opioid dependence. Vivitrol is a monthly injection which can be given to patients who have undergone detox first and want to avoid relapse. It is especially effective for those clients in the early stages of addiction and can be prescribed by any healthcare licensed prescriber. So, the research-based guide to effective drug addiction by the NIDA includes treatment approaches that meet the multiple needs of the individual client, including counseling and other behavioral therapies addressing underlying psychological difficulties and behavioral problems leading to addiction, as well as medications designed to interrupt the addiction cycle. As with many other mental health issues, medications in combination with behavioral therapies are an important element in treatment for many such patients. Housing has also proved to be a critical factor for the addicted population. Having safe housing for such clients keeps the system of care working. Without housing, such clients tend to fall through the cracks. Housing reduces the cost of homelessness and institutional recidivism. It prevents costly shifting to settings such as prisons, jails, shelters, and the ER. It tends to reduce the cycling of clients through crisis-driven systems such as foster care, emergency rooms, psychiatric hospitals, domestic violence shelters, detox centers, and jails. Housing is essential for facilitating recovery. It encourages workforce participation and increases financial stability. Housing creates a foundation for the development and education of children caught in this system. It contributes to the success of children and youth in school. If kids have a stable home, they are more likely to succeed socially, emotionally, and academically. So what's Ohio doing? OMAS, or Ohio Mental Health and Addiction Services, is partnering with the Ohio Council of Behavioral Health and Family Service Providers and the Department of Rehabilitation and Correction and the Coalition on Homelessness and Housing in Ohio to provide an open and transparent system of support for recovery housing. The Bureau of Housing and Recovery Support, created by OMAS, focuses on addressing the recovery needs of persons with substance use disorders through planning, development, and implementation of housing initiatives and statewide activities. To date, Ohio has completed an environmental scan of Ohio's recovery housing. It has held the first Ohio Recovery Housing Conference. It created quarterly recovery housing resource meetings and has become an emerging affiliate to the National Alliance of Recovery Residences, NARR, to include local coalition building and establishing quality standards. Finally, it developed a learning community that includes in-person and technology-based forums. So Ohio continues to work to develop a recovery strategic plan and explore ways to support quality recovery housing. Other projects underway include establishing an 80 milligram opioid prescribing guideline for licensed prescribers, to establish a Southern Ohio treatment center, to work on an addiction treatment pilot program, to create a neonatal abstinence syndrome protocol, and develop a protocol for buprenorphine. It also is going to create additional medication-assisted treatment protocols, and it's important to keep the discussions ongoing or to start talking about things. I want to thank specifically Orman Hall, the Governor's Cabinet Opiate Action Team, and the Ohio Department of Mental Health and Addiction Services for their contributions to this presentation. Thank you very much.
Thank you, Dr. Dapper, and thank you for joining us for today's presentation. You can view the rest of our webinar library by visiting our website at ohpsych.org. Please remember to return your completed answer sheet with payment in order to receive your CE for today's presentation. Contact me with any questions at jbowman@ohpsych.org or 614-224-0034. And thanks again for supporting OPA's webinar series.